Thank you very much, Karin. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Very good morning, ladies and gentlemen. Firstly, thank you very much to the organizing committee for inviting me. And secondly, thank you as well for when they invited me, giving me the freedom, the liberty to choose a topic. I do talk a lot about leadership, and what I've decided on this morning is to share with you a bit of a story about advocacy and why, firstly, it is quite a difficult conversation, and specifically for this morning to talk about how do we advocate for cancer survivors or people living with cancers. So what is advocacy? I think this is very important for us to understand. So advocacy is not just about lobbying. There are several key words here that I would like you all to remember. Firstly, it is strategic. It's something you do on purpose. It is a process. And it's about sharing knowledge. And the sharing knowledge is not just about to increase the level of awareness and knowledge of the recipient, but you're hoping through that message he will change his behavior, his beliefs, so that they can change policies or practices that affects people's life. And while the context of what I'm going to talk about today is mostly about policy making, but you can also use advocacy to mobilize communities. Because nowadays, if you want to move issues, and I'm speaking here, Prof. Aisha is a strong advocate for cancer care, and Murali, where's Murali? He was here. Anyway, the speaker after me is also a strong advocate. It is about mobilizing communities as well. So how do you get people to move? Okay, or to change their behavior. And why do we need to advocate? In fact, this very event that you are attending is an advocacy event. Okay, there are many reasons for you to want to advocate, and I've got this listed on my set of slides. It can be about improving access of care and treatment. It is about support and awareness. It can be about research and funding, policy change, about the quality of life and education and empowerment. So I started off talking about telling you a story. Okay, so photos of my parents. All right, my mom in particular, she has survived breast cancer twice, and in fact, Prof. Aisha is one of the treating surgeons. The second time she had breast cancer. I've got a very strong family history. My baby sister was diagnosed with cancer quite earlier on. She survived that as well. My other maternal aunt passed away. Another cousin also survived breast cancer. So that's the reason why I advocate for cancer. And although my work now don't revolve exclusively around cancer, people who work around cancer, Prof. Aisha, and the NGOs know that they have my strong support in moving their agenda. So why I'm sharing with this with all of you, we all have our reasons why. And I'm talking to a converted audience, in fact, because that's why you're in this room in the first place. You believe that this is an important issue that you want to learn more about. But there are a lot of people out there who are not aware of the issues. And this is what and why we should be advocating. And where can we advocate? What I'm showing on the slides here is the full continuum of cancer care, which starts off from prevention, early detection, treatment, and then down to rehab and palliative care. All right? That's the full continuum of care. And you can advocate at various points of this. The question from Code Blue just now is about screening. Yes, it is not just about issue of access, but when screening is available, people are still not using it. So I give an example, not specifically cancer screening, but for NCD risk factor screening. So why is it when my colleagues tell me the uptake for screening, even when they do outreach, is lower in the low-cost flats in Pulau Pinang compared to Kuala Lumpur, even when you account for the ethnic differences? I don't have the answer because people don't really do research on that. It's not really sexy research, behavior research. You know, Prof. Karin knows this. But behavior research is something that we need to really understand why Malaysians do the things that Malaysians do. So one of the research have shown that kenapa orang Malaysia, why Malaysians do not want to get themselves screened is because I do not want to find this. No, saya tak nak cari penyakit. That's the Malay word. The English loosely translated with I don't want to look for a disease. So no amount of increasing awareness and knowledge will address that, right? Because in their head, I'm healthy, I go screening, I find disease. So why do I want to do that? If you get what I'm trying to say. So I do not have, again, the answer to that. But I think this is a very important question for us to answer. So anyway, that's advocating for early detection. All right? And so on and so forth along the continuum. Most of us probably will survive cancer. And that's where rehab will come into play. You know, how do we survive cancer well? Work opportunities after you survive cancer. The stigma still there associated with cancer. So there are a lot of issues. What I'm trying to say here is issues is not just about advocating for access to treatment. Yes, treatment for cancer is expensive, but I hope that we are not just focused on that bit. When we know that a lot of people are still not accessing care for various reasons. My maternal aunt who passed away, it was her daughter that survived cancer, but she kept it quiet until it was stage 4. And she lived only, 5 kilometers from IKN. All right? So she has seen someone survive, her own daughter, but yet she has decided, for reasons unknown to me as well, why she decided to keep it quiet until it was already fungating. Okay? So, and that's one of the reasons why the stage 3, stage 4 in Malaysia is still high. It's not because lack of access. Of course, issue of screening is still there. But even we do know that even when we do catch them early, stage 1, stage 2, they will default treatment or decide for something else. And it's not related to level of education in some other countries. And then they come back stage 3, stage 4. Hence, you know, no amount of institute cancer will address that. No amount of outreach will address that. So there are other things, and I'm advocating for that component right now, actually. Right? The focus for research is very much geared towards that other end of cancer, but not so much this end. All right? Okay. I'm not going to talk about how exactly you do advocacy, because that's a different set of lectures, and Murali being... So Murali just embodies advocacy. You know, when he stands up here, he is the advocator. You know, dia cari makan being advocator. Whereas we all, macam Professor myself, is part-time advocator. And we all, she's a surgeon. So I'm not going to talk about that. But there are some key things about advocating that I would like to share with you. So the first question I have for all of you, I'm not going to pick any of you to answer this. You know, think about what you have done in the last 6 months or a year that you would consider advocacy. Have you talked to someone to convince them to change their behavior for a particular issue? Okay. I'm going to focus a bit more on policy making. Okay. So one of the theories in policy making is what we call the kingdoms theory. All right. There are many other theories, but I like this one in particular, which describes 3 streams. First, you have your problem stream, then you have policy stream, and lastly, you have your politics stream. Okay. So the problem stream describes there is an issue. All right. So what's the burden of disease? How is it affecting the population? The second stream is what are the possible solutions. But even when you have the problem well described, and when you have options of possible solutions, then you have the third stream, the politics stream, because how do you make people who are involved with the policies to be convinced that they need to be committed to this? And when we talk about politics, it's not just about the politicians at the top. It is about the constituents at the bottom as well, because politicians respond to what the constituents say. So it's not just about top-down, but bottom-up Okay, apa dia rasa rakyat dia, the population will say. An obvious example, one of the things we were talking about was about limiting the opening hours of 24-hour restaurants. Okay, not so much about weight management, it's more about unhealthy behaviors. Right? We'll see KJ in the afternoon, but KJ just said outright to me, he was health minister, I'm not going to touch that policy. It's not going to be politically feasible for me to touch that policy. Well, I like him because he's straightforward, no beating around the bush. So yeah, fine. But he was taking on the Tobacco Act at that point in time. So I was willing to let it go. But that's what I mean, all right? So even if you have the solutions, but you don't have that stream, then it will not come together. So you need all this coupling, all these policy streams to come together for it to happen. Okay? The health white paper right now, problem stream well described, policy stream, we have possible solutions. I'm not sure about the politics stream at the moment, all right, whether that will come together or not. So that's another example if you want to talk about the health white paper. So moving on from that policy theory, you have your stakeholders. I'm just going to talk about stakeholders here. Stakeholders are not just about people who can affect the change, but also people who are affected by the change. And don't forget, some policies have unintended negative consequences, and that's what people are more concerned about. All right? And if you don't identify this well, then this is where the opposition will come in later on that you do not recognize. And another term I'd just like to talk about decision makers. So when you advocate to people, it's not just about people who can make the change, but who can influence, right? People advocate to me because they know most of the time I don't make the change, but I can influence people who can make the change, right? Sometimes for community work, sometimes it's not easy to talk to the head of the village. Perhaps for some of them, it's easier to talk to the wife of the head of the village, okay? Or the special officer, So that's what I meant by influencers, who can influence the decision makers. And once you have your stakeholders, part of the thing that you need to do with your list of stakeholders who you want to advocate is to do their analysis. And this is where you want to determine what their levels of power and influence and what are their positions. All right? That's just one way of doing the stakeholder analysis. There are many other ways as well, where you create this, what we call the influence interest grid, and you determine where they stand within the grid. And if you look at the top right-hand corner, those are the key players, high influence and high, support you, and those people who do not support you, but with very high influence. There are many. What I'm saying here is not just about one way of engaging people. There are multiple ways of doing your advocacy depending where they sit in your stakeholder map. All right? You do not just engage people who are in support of you. You need to understand who are also influential but not in support of you, but you engage them differently. Okay? So advocacy is not just about finding friends. It is about knowing your enemy. Well, not saying you need to know your enemy and sleep with them, but keep them close because they will come back to you anyway. All right. Okay, I'll stop there with regards to that stakeholder mapping. I just want to keep the time. And you need to understand your stakeholders. They are human beings as well. They have their priorities. You need to understand what motivates them, what's their background. And these are some of the things, okay? So this is where, if you identify stakeholders, it's not good just to call them for a meeting and meet them all together at the same time because they are all different. This is where personal touch comes into play. That was it. That's where, if you work for pharmaceutical companies, right, they're really good at stakeholder mapping. Yeah, I know because I get played. So, a player knows when he gets played. Okay, so they do this very well. Okay, and okay, just two slides about qualities of a compelling message. This is where I tell my team from Perak when you see me, I'm time poor. I'm time poor. I don't have time. So whatever you want to tell me, just get straight to the point. Don't waste time. Yeah, you have a 30 minutes appointment, but after 5 minutes, you will lose my attention anyway, if you're going to get straight to the point. Whatever message you want to have, it has to be solution. Okay, and don't focus too much on the problems. Kan, semua orang nak mengadu kan, everybody's telling problems. But be focus on the solution, and at the end of it, have a very clear request. Okay, Tuan Pengarah, can you blah 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 blah. Okay, and the other way to look at the advocacy message is something that I hope some of you have done the elevator conversation, right? So suddenly you go into the elevator, you look up, it's the health minister, and it's 30 seconds. So, and you have a specific request for the health minister, or even PMX for that matter. So do you just say, my name's Faizul, or you have something else to say? All right. So some of the four parts of a very quick advocacy, message is that: what is the issue? Why should you care? There are solutions, and I have the solution for you. All right. So it has to be quite succinct, and with any competency, and advocacy is a competency, you need to do it often, get feedback for you to get it right. Okay, any competency. Professional surgeon kan, bukan suddenly you become a clever surgeon overnight just by looking at other surgeons doing it. You actually have to do it and get feedback. Competency, advocacy is also a competency, a very important competency. That's why I would like to, that's why I choose to speak about it today. Because, there's a lot of skills just for advocacy. It is acquired, over many years of practice. You're not necessarily born with it. Okay, it's something that you can learn over time and be good at it. And I think as healthcare providers here, most of you, or if you work in the healthcare space, or if you're championing for people living with cancers, I think this is a very important skill set, in addition to leadership, for example, and negotiation skills as well. Those are very, being a salesman, really. These are very important skills for us to work in the healthcare arena, especially now. If you can't remember anything what I'm telling you today, please remember this. You firstly have to acknowledge that people do not make decisions based on facts. Okay? Otherwise, it's easy for you, for my FMS down here, just to tell a diabetes patient, Pakcik, if you don't take care of your diet, there's a 50% risk of you getting XYZ. Paper has been published in Lancet already. You think the Pakcik cares or not? But that's a fact, right? And most of us do not make decisions based on facts. We make it based on emotions. That's how advertisers get to us. Okay? Secondly, we need to be prepared for that window of opportunity, or if you can create that window of opportunity where the three streams, if I use the Kingdoms model, to converge. Third, you need to know and manage all your stakeholders well, and this is where Murali is really good. He knows how to take care of me, I know. Yeah, and there are other skill sets as well. Being an advocator is not just about being an advocator, negotiator, be a lobbyist, and also be a salesman. So I hope I'm still trying to practice to be a better salesman. So I hope I've managed to convince all of you that advocacy is a very important skill set right now, and all of us can play our role being an advocate. You know why? Because you know why? Because this is where we stand. While we talk about cancer today, you are advocating against all of these other background issues. Even within the NCD space, if you look at what are the main drivers for death among Malaysians or even globally, it is still cardiovascular disease. Well, cancer is coming up very strong because a lot of people surviving cancer, they will die of something else, and we will most probably die of heart attack and stroke anyway, most of us. All right? So you're advocating against all of these other issues that we face globally right now. So that's the challenge that we face as advocates. So how do we raise our issues against all of this noise? And in my current role as the director for the state, of course, I get a lot of issues coming my way. So if you are cancer, people fighting for cancer, people living with cancer, how do you raise above all the other noises like dengue, not enough MOs, my equipment, all old equipment, my hospital falling apart, all of that. No, these are serious issues. I'm not belittling, but how do you get your issue to be above all of this? Okay, and so that's my own quote. Sorry, not somebody else's quote. And that's the QR code for my LinkedIn. I'm more than happy to communicate and to pick up any conversations that you would like through LinkedIn. Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Faisal. We're happy to take a couple of questions.
Rasha.
Thank you, Dr. Faisal. Nice talk, Dr. Faisal.
You're biased.
Ya ke? Alah, tak adalah. Okay, so anyhow, I would like to ask you as a policy maker. I mean, it's one thing for us advocates to try to get our agendas to the policy maker. Does the policymaker make decisions based on evidence?
Itu senang je nak jawab. Okay, firstly, I wouldn't describe myself as a policymaker. I would describe myself as a policy designer. Okay, final decisions are not by us technical people, really. Yeah, no, that's the reality, right? At least for the policies that we talk about. Okay, at that level. Maybe I can decide on how the hospitals get run on certain things, but that's not what you're asking, right? The reality is, while there are facts or evidence being used in decision making, even an example that I use for the 24-hour restaurants, other factors come into play. And this is where I think it's important for advocates to acknowledge that. Because sometimes they look at us and they say, apalah bodoh sangat ni korang ni, aku dah tunjuk bukti pun, orang tak nak buat-buat lagi dalam hati lah. In your heart, you say they're so stupid. That's like you saying your patients, okay, come on lah, man. Okay lah. This last time I've been a doctor treating patients was many years ago, but I still remember, why lah this patient don't want to listen to me? I'm sure you all had that feeling, right? And that frustration. Decision makers are human beings as well. And so, if you could understand the other factors that may drive them to in making that decision, perhaps you can make some headway, trying to address. I think in one of the earlier slides, to understand your stakeholder, what are their concerns, and maybe for a patient sitting in front of you, maybe they have other concerns, right? I use the word diabetes because I worked with diabetes for the longest time, right? If food is the only thing that giving them pleasure in life, the children don't live with them, husband don't care about them, food is the only thing, and then now suddenly you're telling them they can't eat. So they won't listen to you, right? Because they won't be deprived from, but then again, I'm not saying give up on food. Then let's try to negotiate on that bit rather than keep harping on the evidence. So yes, evidence form part of it, which goes back to the question about leadership. I think leadership, a good leader has to be a bit more transparent, a bit more engaging, and I think that's where we're lacking.
Test. Hi. I'm also actually Prof. Aisha's RA, but just wanna ask a question. I have a question. So I'm not really part in the healthcare system and not very familiar with Malaysia's healthcare system, so I think you would be the most suitable to answer my question. So if someone wants to advocate for an issue relating to cancer or other types, and you mentioned about political will is very important, is there another way for Malaysians to advocate that does not depend on the politician's interest? So for example, if I'm interested in prevention, and let's say I'm also interested in I'm not sure if anyone's aware, but like Shein, the type of fast fashion has a lot of lead. There's a lot of chemicals inside the clothing that is contributes to cancer. I don't think if I tell the health minister, he'd be very interested in it. But I think, like, is that another pathway that I can take, so that, or any other causes? Is there another pathway that I can take that does not depend on only the politician's interest in it? Thank you.
I won't be answering. Sorry, nama? Right, Intan. Dia kata bukan Prof punya RA. Mesti ada strip of her identity. Thank you very much, Intan. A very great question. Firstly, if you talk about making changes in the country, it has to be a combination of top-down and bottom-up. All right. Bottom-up means you have a very strong civil society, which we don't. If you look at developed nations, they have very strong civil society, and this is where I think, and this is why I do support the work done by Murali, trying to get civil society to be stronger. Okay. What I skipped in my slide was about partnerships in advocacy. So you don't have to work alone. You need to find like-minded people, not just have to be individuals, but organizations as well. And again, this is what Murali is doing, trying to get all these organizations together so that you can have a stronger voice. Everything needs to start somewhere. I don't have to necessarily, buy into your concerns, because I have other concerns at the moment in time. But that should not stop you from talking about it, building your base. It is work. It is hard work. But if you talk about people who have done work at the grassroots level, they all started somewhere. So I will not stop you. I think the best tip I can give you is talk to people who do a lot of work in it. That guy there definitely kena banyak bagi I, honorarium. I banyak promote Murali ni. Okay, no, seriously, talk to people who are champions. Learn from them. Okay, and while soft skills can be acquired over time, but nowadays there's a lot of courses on this kind of thing, which was not available many years ago. So there are ways for you to shortcut that. Okay, so just gather your evidence, get your partners, okay, and slowly find opportunities when you can. It has to be the coupling thing, the coupling that I showed you. It cannot be on just a standalone thing suddenly out of the blue. If there is an opportunity, then you come forward. Okay, it's always like that. Just wait for opportunities. Yes, sir.
Hi, Dr. Faisal, great insights. I'm Jonathan from Kelsis. I'd like to ask you one quick question. How can the private sector help you in the public sector to meaningfully close the cancer care gap and improve survival rates? And especially, what are the low-hanging fruits that we can do that can make a meaningful difference?
Thank you, Jonathan. I sat into your presentation. I think that's something interesting that you are proposing. When it comes to working with the private sector, I think the first thing that we need to acknowledge, I think there are two major challenges. One challenge is that the rules of engagement between the public and the private is not very clear. It's very what I would describe as discretionary. That means if minister likes you, can lah, change minister, cannot already. Discretionary. It's not systematic, and the process is not as transparent as I would like it to be. Second, within the current healthcare system, I can't see anything that is sustainable over time. I can't see anything that we do right now will be in the form of a crutch, temporary. Right? We need that healthcare transformation to enable us to make more meaningful work, more meaningful with the private sector. I can't see. I've been trying. And relating to the point number one, because there isn't any clear rules of engagement, that's why there's a lot of reluctance. Okay? So if you a bit more daring, maybe you would, to play safe, just go away, find someone else to play with. I would also describe the other challenge within the space that you are working on right now is because when it comes to cancer, it's not just about health, it's about their social and welfare, which is beyond the healthcare sector. So how do we then convince the other agencies responsible for those components to be on board as well. That one I've not really explored. So I will not be able to give you a good answer for that, Jonathan.
Thank you, Doctor. We have one last question.
Thank you, Dr. Faisal, for the nice talk. I'm not quite sure whether this is the right platform to ask, but I like your word on designing a pathway, or your way of working. I'm a primary care physician based in UMMC. I'm also part of Prophet Ashraf project. What I know from the FMSs, the Klinik Kesihatan, they have a lot of sub-programs, elderly and adolescents and whatnot. So I was just thinking that in terms of like designing what primary care physicians are doing, there are quite a lot and there are so many patients. And I wonder if I know you have got your KPI, to meet up and all that. Is there any chance that certain KKs are championed in certain programs, and other KKs are can focus on other things? Because in Sabah or Sarawak they might not have a lot of adolescence issue, maybe, I don't know, and in Selangor maybe you can focus on more of like urbanization, aging, and whatever that you can design. Thanks.
Oh, that's an easy one. The guys in Perak can answer that for you. It's an easy yes. I do give my team the ability to decide what's important to them, what's not important to them. And I tell them whatever KPIs that come from ministry, as long as you provide me an answer, even if you don't achieve it, then I'll have your back. So again, goes back to leadership, how much you want to be able to, but at least I can assure my team in Perak. And that's one of the key things I did when I started in Perak. Regardless of the KPIs, some KPIs may be more meaningful than others, but ultimately in resource constraint settings, which I work in, we do need to prioritize. And in view of the current situation that we face, with increasing burden number of patients, and reducing number of healthcare providers, then perhaps it comes a time for you to prioritize, for us to all to prioritize. So yeah, at least in Perak, I have assured my team, I got their back. But they have to do the work lah. Huh? They cannot be telling me cannot achieve everything. I cannot like that. Okay? Yeah. So go back to leadership.
Good morning, everyone.
Okay.
Thank you, Dr. Faisal, for your talk. I'm Janice. I'm a pharmacist from Hospital Teluk Intan in Perak as well. So I would like to address a question in regards to some challenges in lack of resources. How do we emphasize behavior change, especially with taking into account the social determinants of health that do exist on our patient level? Thank you for...
Oh, that's a very broad question. Again, very relevant, not easy for me to understand. And that's one, okay, so I'm gonna not really answer that question. Even many years ago, I was already discussion with the behavior scientists, clinical psychologists, even Karen here, when it wasn't popular about understanding behavior. And how do you choose which patients you spend a bit more time and which patients you don't spend too much time? If you look at how we do tobacco cessation program or quit smoking program, one of the models that we use is the trans-theoretical model of change, where you determine what level of change they are. So, and that's for smoking. Perhaps we can use that for diabetes as well. If the patient is not even thinking of, so it is unfair, because then they argue with me, doctor, if they're not willing to change, you just ignore them, ke? But then I will counter back, you only have so much time within our current system, unless we have other tools at our disposal to enable that. So where do you spend your time? I would suggest you spend your time worthwhile with patients who are willing to make the change, no matter how unfair that seems to be. And it is unfair. Okay? But when you have resource constraints, you have to make difficult decisions. Okay? That's why we need people like yourself to start thinking of how we can do this better within the constraints. Because that's a solution, Keep asking me, doctor, and the hospital pengarah there, sitting there, not enough MOs lah, everything lah. I be smiling at them, being polite lah kan. When I can't even find the MOs, where do I find the MOs? They're all resigning en masse. So let's focus on the solution. So firstly, how do we select patients better? And secondly, how we can do that engagement that we have more meaningful. In my work with diabetes, even with the direct observation that I did part of a study, you'll be surprised, within that 2 minutes, the doctors is doing all the talking and the patient don't have any opportunity to say anything. Whereas you can use the 2 minutes to actually ask the patient one question and let him do the talking so that you can understand it better. So it doesn't have to be more time. But because you see your seniors doing it and you think that's the right way, so monkey see, monkey do, unfortunately. All right? So that's where we need to start trying to see how we... Actually, if you talk to patients and we talk to doctors, what they say is completely different, The doctors will say patient don't want to hear what we say, kan? Patient degil tak dengar cakap. The patient will tell you, doktor tak bagi saya peluang pun bercakap. So that's a different set of lecture. Sorry, we're on the wrong topic here. Yeah, so we need to find way to select the patients that we spend a bit more time, and the others within the current tool maybe just give the leaflet lah, and ask them to move along, or YouTube video, whatever lah, whatever the patient looks at right now. Okay, I think I'm over time. No?
Thank you, Dr. Faizul. And now I invite Prof. Chan to present a token of appreciation to Dr. Faizul.